Good morning, everyone. I see Dr. James Chuang just signed in. So I think our class will be 2 hours today. And just let you know that I will be the host today. I'm Catherine Lau. I'm the Teamer in New Jersey member. And we are trying to take the opportunity to kind of introduce the Vision Mobile Clinic to New Jersey, and we are getting the equipment this year, and then hopefully we can start the outreach in the fall. So really grateful that Dr. James Chuang is able to take the time out of his busy schedule and then perhaps give us an introduction to the Vision Mobile Clinic. And on May 27th, Sunday, Stephen Boone and Olivia Chung will be coming to the East Coast to give us the in-person training. So Dr. James Chung is a leading teamer doctor in New York City, and also I think that he's one of the teaching alums. So welcome, Dr. James Chuang. I'm going to hand this over to you. If you have any questions, you can simply use the icon on the bottom to raise your hand, so I can let Dr. Chuang know that you want to have some clarity on some of the concepts. Thank you.
Good morning, everyone. Dr. James Chuang. It's good to see some familiar faces and some new faces, and we're going to try to go through as much as we can today. Normally these classes are broken up into 2 classes plus a hands-on training, but in the interest of time and in the interest of trying to get everybody together, this would be the best way. And so let's get started. I am Dr. James Chuang. I've been practicing for a while. This is my practice. This is where I've been for about 15 years now. And then on my Wednesdays where I'm off, and on the Sundays where I'm off, we do to see Vision Mobile Outreach. These programs have been running for a while. I'm going to kind of put the screen this way so that I could kind of see what's coming up next. So these programs in New York, we've been running for about 3 year-ish somewhat, maybe just a bit longer than that. And so far we're getting more successful and more knowledgeable in what we're doing and in going out. And I believe New Jersey is also trying to start up their own vision program now, which is great. Congratulations. I hope everything works out the way it has been for New York. And so what happens, so this may not apply to New Jersey, but it'll be very similar, and the growth should be very similar. And from what I understand, the New Jersey program would start at the headquarters, and it would be with portable equipment. For us here in New York, we have mobile vans, which we go out to each site. We have the optical van and we have the vision van. One is for eyeglasses and one is for examining the eyes. And so for the vision van, this is what it looks like. We have all the equipment inside to do a comprehensive eye exam. And we can actually dilate and do retina complications too if we need to, but these programs are geared more towards making eyeglasses, and as such it would be a more of a routine exam versus more of a medical eye related exams. And as such, these equipments are generally more geared towards just giving a routine comprehensive exam versus, if you have retinal issues, you have cataract issues, you have glaucoma issues, these issues generally will be referred out to the local optometrist or local ophthalmologist as needed. Then going on, we have the optical van, and the optical van has the eyeglasses, and if you see that wall there, the separation on the other side would be where we have the edging machines and the tracing machines to make the actual prescription for these patients. And I guess for now, the TZE office in New Jersey, we will have portable equipment, which is similar to these, but they will be more handheld. And it would be a room inside the New Jersey TZE office. And then we will have a dispensary inside also. And so it would all look very similar, just the setup's a little bit different. All right, so what we do when we go out on these mobile outreach is that there's generally a flow that we try to go through. And the flow is that you have your patients come in, they would have to register essentially their information, their health information, their vision information, and also all the signatures that are required. This would then be passed on to the next team, which would do the entrance exams. And the entrance exams consist of just basically doing a basic entering vision check, color books, stereo books, to check their eyeglasses if they have any on hand. And then there would be a machine called an autorefractor, NCT. So this is a machine that can actually get an idea of what a patient's prescription is, and it also will take the eye pressure of a patient's eye. Generally, this is a combination machine, but the machine can also be separated. But at TZE right now, we use a combination machine, which I have some pictures in a bit. Afterwards, the patient would then go to see the eye doctor, whether the eye doctor is inside a room with portable equipment or whether the eye doctor is outside on one of the mobile units. They would go out to the vision van. After the eye doctor checks the patient's eyes, then the patient goes on to the next room, which would be the optical area. The optical area would have the eyeglasses where patients could try out the eyeglasses as they need. Once the patient picks out the eyeglasses that they like, then we would pass this on to the next team that makes the eyeglasses. And then the patient would go to a waiting area or a waiting room. And then once the eyeglasses are done, then we would bring it out to the patients. Patient would try on the glasses to make sure everything's okay. And then we would have them sign essentially a pickup or acknowledgement of pickup receipt. If anyone has any questions at any time, just feel free to stop me. Feel free to just kind of ask questions. We only have about 2 hours. I'm going to try to see if we can fit most of these in. I'm going to try to see if we can do this registration part in the first hour, and then we'll see if we can try to go on to the entrance exam or the pre-testing in the second hour. Okay, so for the patient file registration, I have pictures of what that form will look like in a bit, but it will consist of patient medical history, patient's consent for treatment. It's very important that we get patient's consent. Patient signature must be on these forms. Just because we do these outreaches doesn't mean that we can just do anything willy-nilly. Everything has to be legally signed, legally presented. We also want to be professional in what we do. And then also we have the patient vision consultation form, which is on the back. If we kind of skip forward a little bit on these slides, it's essentially what the consultation forms look like. On the left side is the front page. On the right side is the back page. And if you see on the left side, the front page, we have the medical history, your eye history. Dilation, we generally don't dilate at this point. But if we ever do, it's very important that is signed. The most important part of this first page is that bottom area. The bottom area is the consent for treatment. Consent for treatment must be signed and initialed. On the right side, we have the exam form. The exam form itself, the top 2 boxes where would be where we fill in for the pre-testing, and then the bottom areas will be where the doctor fills in. So let's kind of go back here. Generally, skip one. Generally, in the past, we usually have a vision assistant assisting the doctors. And what happens is the vision assistant would kind of help the doctor keep the flow of the patients, help the doc tally and log each patient. This seems like it's not much, but when we're doing these outreach, we generally try to see as many patients as we can. And so anything that we can help the doctor that day do would actually allow him to see more patients, or him or her to see more patients. The vision assistant also will write the final prescription on the prescription form. The prescription forms are given to the patients when they pick up their glasses also. In America, after an eye exam, a valid prescription must be given to a patient, whether the patient asks for it or not. That is actually the law. And then also the vision assistant would help that patient transition on to the optical area, whether it's the optical mobile or whether it's the optical dispensary set up inside. Let's come to patient privacy. Patient privacy is very important. HIPAA is very important. I am actually going through a lot of these pretty quickly. If anyone have any questions, please feel free to ask. But HIPAA is as such that it protects the patient's information, their privacy. We should be more careful in that we try not to say too much to anyone or to any other patients. So HIPAA protects information that the doctors know, what we put in the records, what we speak to each other about. Anything regarding a patient's information must be protected. In terms of HIPAA, when we usually go out on these outreach, there is generally just one eye doctor on hand. And that eye doctor's license is what's going to cover everybody on that vision team. And so it would be very important that when you as a volunteer are speaking to other patients, be more mindful of what you say and what you do, because in essence, you and the doc act as one, and what you say essentially would be construed as what the doctor says, just because it's the doctor's license that's covering everybody on that vision team. And as you see here, if a patient came with somebody, usually maybe a translator, the translator is essentially under the umbrella of the doctor. Unless the patient says, look, I don't want this person to be here, or I would like them not to know my information, then the person is covered under the doctor's umbrella. And of course, less said is better. And if you really don't understand the question of the patient, or it's best that you try to not understand the question of the patient, the response is essentially, I'm not the eye doctor. When you have any questions, please ask the eye doctor later. Or if it's something very urgent, then try to get the doctor's attention, and he or she will come on over and going on and explain as needed. What happens with HIPAA, and this is very common, is this is an example where a husband and wife are patients, and they both come to us to get their eyes checked. And let's say if the wife gets the eyes checked first, and then the wife goes outside, and then the husband gets the eye check second. Generally, the spouse that came in second would always ask, oh, how's my husband's eyes, or how's my wife's eyes? With this, and with regards to HIPAA, the doctor actually and us as volunteers are not allowed to say anything. And this is because the wife information is the wife's information, and the husband's information is the husband's information. Even though they are married, HIPAA does not allow us to say anything unless both is present and the wife or the husband gives consent. So HIPAA is very important. HIPAA is something that we have to take very seriously. And as such, if we're outside and, if we're doing a color test, or if we're doing a stereo test and the patient asks, how is it? Am I blind? You can just tell them how many, let's say if it's a color test, you can just tell them, hey, this is out of 14 pages. You got 14 out of 14, which means you got all the pages, or you only saw 2 pages out of the 14. Let me have the doctor explain this to you later. Please ask the doctor that question. Next, we have infection control. Infection control in terms of what we do. It's not that it's not important. It's just that we are generally not in contact with as infectious a disease or germ as we would in other professions, just because we generally are not going into the eyes. But infection control is also important in that we would like to go on these outreach and not get sick. We also don't want to infect others, and we don't want to get infected ourselves. As you see here, we have good germs, bad germs. Germs are all over our body. They're all over surfaces. But we should still know a little bit about infection control and what we should do. So for an infection to occur, there has to be a source. There has to be a susceptible person, and there has to be a way of germs being transmitted. For us here in this vision program, we are most likely the source, and also the patients are the source, and we may end up being the one that transmits to the patients, or the patients may be the ones that transmit it to us. And so we always have to take precautions. And so precautions for us: hands, wash our hands if we can. Sometimes on these outreach, we don't have an available sink nearby. Then we would use sanitizers. And of course, if we don't have sanitizers, which should not be, we generally should have a bunch of hand sanitizers around, especially now with COVID. We also will have gloves, depending on your comfort level, whether you're okay with sanitizing, or whether you would like to wash, or whether you would like to wear gloves. In terms of the eye, when COVID came, when COVID was pretty severe, we would wear face shields and goggles. Now COVID, it's not that it's not as deadly, it's still very deadly a disease. It's just the mortality rate isn't as high as it used to be. So nowadays, even myself, clinically, I don't wear gloves anymore. I don't wear face shield or goggles. I still do wear a face mask. There are no rules or regulations regarding face masks now. And actually in New York City, the mayor is asking most customers that enter a store to actually remove their face masks, because a lot of people who have bad intentions are actually using the face mask as a way to disguise themselves. But in essence, for us in our outreach, best to wear a face mask. But there are no rules and regulations in New York, that is. I don't know how it is in New Jersey. I don't wear N95 masks anymore. I just wear a disposable mask nowadays. But we do have on these outreach disposable masks, and we also use N95 masks, and we have available if it's something that's anyone or any volunteer wants to wear. Generally, on these routine eye exams, we are not putting any sort of instrument or probes into the eye. And as such, we don't need the 1% sodium hypochlorite. And as such, we only use isopropyl alcohol. And with regards to isopropyl alcohol, it's at the 70% level, which is what you normally would see at the stores. It doesn't have to be the 99.9% versions. In terms of alcohol, there are actually different types of alcohol. During COVID, we were lacking in isopropyl, so you will see actually in hand sanitizers, what's mostly used is ethanol or ethyl alcohol. Try not to use any alcohol on wiping frames or instruments. Isopropyl alcohol would be the only alcohol that we can use because it actually is less harsh on the instrument and the frame itself. Case in point, when COVID came, I was driving with my wife, and my wife used a hand sanitizer on her hands, and then she thought she would kind of clean her glasses, so she used the hand sanitizer on her black frame glasses, and the glasses itself actually turned all brown. And so what happens is that hand sanitizers is usually ethyl or ethanol alcohol. That type of alcohol will actually ruin the eyeglasses. I also have patients sometimes when they go into my exam room, they'll use their hand sanitizer and they'll want to touch the machines or kind of wipe it down after they sanitize their hands. If you see that, please tell the patient try not to let them touch the machines with that alcohol. If they are concerned, wipe the machine again with the isopropyl alcohol when they're present. So with regards to hand sanitizer, stressing it again, make sure the hand sanitizer is dry before you touch anything. And sometimes ourselves, we would use hand sanitizers and just make sure it's dried. If it's not fully dried and you touch the next machine or the frame, it will damage it. Okay. Does anyone have any questions so far? All right, so then let's go on to the next part. So once again, we have the consultation form. So when a patient comes in, they would sign a whole bunch of acknowledgement regarding HIPAAs. And then we also have the consultation form, which needs to be filled out, which is the front page or the picture on the left. And the picture on the left, registration area would kind of take care of this part. We first go through the medical history. Medical history, as you've seen here, this is a little bit more blown up. It's a little bit easier to see. We have your typical medical history, whether or not you're pregnant, whether or not you're nursing, on birth control. The major medical histories, which is diabetes, heart disease, any sort of headaches, blood pressure, cholesterol, or any allergies to any medication, and any medicine that they're taking now. These are essentially the basic medical histories. There may be some pushback from, and this is what I see from mostly Asian patients, but not to generalize. There are patients who say, hey, look, I'm here just to get eyeglasses. Why do I have to tell you these? Why do you need to know if I have high blood pressure? Why do you need to know if I have diabetes? Just check my numbers. Check my numbers, just give me glasses. And what happens with this is because in the other countries, patients can actually go and get an eye exam and get eyeglasses, and they don't have to check the eye history or ocular health or the health of the eye. And that's not the case here. In the United States, Essentially, only a licensed eye doctor can give an eyeglasses prescription. And to get an eyeglasses prescription, you have to get a full eye exam. And to get a full eye exam or a comprehensive eye exam can only be done by an ophthalmologist or an optometrist. So in essence, a routine or comprehensive eye exam can only be done by an eye doctor, and an eye doctor cannot ignore the health aspect of the eye and just refract the patient. And refract means just to check the prescription. And so when we have to do a full eye exam, we have to know a patient's medical history. And the medical history helps us kind of know what to expect if a patient has diabetes. Sometimes the blurriness is caused by the diabetes and not because they need eyeglasses. And the blurriness could sometimes be because there are issues on the retina. There's some sort of retinopathy. And diabetes is the more common one, but blood pressure, cholesterol, and all these other medical issues can actually cause issues on the retina. And the issues on the retina, then you can have distortions or you can have blurriness. And this is not just a purely glasses issue or something that glasses can fix. This is more of a medical issue where they would need further follow-up. And sometimes some of these changes can be very subtle, and so we can't fully tell whether or not it's just a glasses issue or whether it's a eye health issue. And so it's very important that we do, or the eye doctor do know all these medical problems if it's there. Let's come back to the consultation form again, and now we have the eye history. And the eye history would be where the eye doctor is a little bit more concerned about, in essence, because we don't want the patient to go blind, or at least the running joke in school is that we don't want to be the last eye doctor to see the patient go blind. And as such, we have to make sure that the patient's eye history and health history is good. And this is a close-up of what the eye history part would look like. And the eye history part here, as everyone can see, we have the glaucoma, the macular degeneration, the retinal detachments, the cataracts, any sort of eye history, any sort of eye surgeries, and any other eye issues that the patient may want us to know about. So maybe something happened when they're younger, or maybe they fell or had some sort of surgery, or maybe something happened when they were 3 that they're not too sure about. At least it makes the eye doctor aware that something may have happened. In terms of glaucoma, there may be family histories association in terms of macular history. There may be family history associations. And so eye history is important in that the eye doctor knows what to expect. And also if the patient cannot see or read well on the charts, we may already have an idea just because of what their eye history tells us. Okay, so let's come back to the consultation form again. Then right below the eye history would be the dilation. And this is a close-up of that part. In terms of dilation, in terms of dilating the eyes, this is something that we normally would do clinically. It's just that when we go out on these outreach or when we do these community vision programs, we generally don't dilate the eyes. If it's serious enough or if it's complicated enough, we will refer these patients out to the local ophthalmologist or the local optometrist. But in terms of dilating the eyes, what that means is that the eye doctor will put eye drops inside the eye, which will open up the pupils. There are generally 2 types of eye drops that we put in the eye. One is tropicamide, one is phenylephrine. And usually the dilation effect would last about 3-ish hours, give or take. But if we do use 2 eye drops, it would last generally maybe up to about 5 hours. Now, why do we need consent to dilate the eyes? One, we're putting medicine in a patient's eye. Whenever we put anything into anybody's body, we always have to get consent. It is a medical procedure. Dilating the eyes does come with its own precautions. In small percentage of cases, which is very small, dilating the eyes can lead to angle closure. Angle closure, a patient will go blind pretty quickly. And so dilating the eyes is not a very simple procedure. Most of the cases, most of the times, there are no issues. But dilating the eyes does have that small percentage of problems. Dilating the eyes also will make a patient's vision blurry. If a patient has astigmatism especially, or if a patient is farsighted, they will not see too well. In the other states, generally most patients drive to come see the eye doctor. They would have to drive home. So it's always best to let the patient know that you will be blurry for a few hours. It's best to have somebody drive you, come with you. But most patients actually do end up driving home on their own, just very carefully. In New York City, I generally don't dilate unless a patient has somebody with them, just because it's more of a crowded and more of a hectic city. So as I was trying to say before, dilating the eyes does allow us to get a more thorough checkup of the eye. And it's because when we dilate the eyes, it's kind of like opening up the window. And when you open the window, you can see more outside. And so dilating the eyes is to open up the pupils in the eye. And then once again, dilating the eyes has a very small percentage of angle closure, which can lead to blindness. But for now, once again, we generally, and we usually don't, we don't have any eye drops available in these outreach or even in the vision vans anyway, so we don't dilate the eyes when we go out on this outreach. I heard from Steven out in California, I believe some doctors do dilate the eyes. It's possible, depending on the doctor's comfort level, and I believe in New Jersey, if the doctor is comfortable and if the doctor wishes to, I mean, that's something that can be done. Just know that when we dilate the eyes, once we put the eye drops in, it takes about 20 minutes or so for the eye drops to take full effect. This will actually slow down the whole flow too. So dilating the eyes will actually slow the whole process down by a lot. It's not that it's not possible. Normally what we do clinically when we dilate the eyes is we would see 2 patients dilate one eye and then see the next patient and then follow up with the dilation afterwards. So it is still possible to continue the flow, but the doc would have to be pretty darn efficient if you were to dilate the eyes, and also the flow has to be kept very, very tight. Okay. Anyone have any questions regarding dilation, dilating the eyes, or anything we spoke about? Can somebody make a sound so that I know that everyone is still there?
Dr. Zhang, this is Sulin from Philadelphia. I do have a question need to ask.
Yes.
Okay, so I was helping the vision station last year in New Jersey, and we have to do the intake form, right? So when clients come in, we ask the question. One is glaucoma and one is cataract, and then somehow most of them they don't know how to tell, and then we don't know how to find it out the problem they has.
And this is very common with patients when you ask questions. Even their medical history, sometimes they're very unsure of. Generally, if a patient doesn't know we leave it as no, and we let the doctor try to figure out, if they can, what's going on. So in essence, if you ask them if they have glaucoma and they don't know, then generally that is a no. If they do, they would usually be on eye drops, and they would usually know what that is. Cataracts is a little bit more complicated. Cataracts, most patients may not know or remember what their doctor tells them. Most older patients, usually 50 and up, you will see some sort of cataract. So most patients these ages actually do have some sort of cataract, but it may not be hurting their vision, which means that they may still see very well. And as such, the doctor may say, you do have cataract, but it's not affecting your vision. And most patients would forget about that and just think that they don't have cataracts. So usually if a patient don't know or doesn't say, we would leave it as no until they really do say something. And usually these issues, if it's severe enough, the patients would know. Does that answer your question?
Yes, thank you so much.
So then let's come to the next part of the form, which is the chief complaint. And the chief complaint is actually on the other side now. So this chief complaint is on the right side, on top there. And I know these forms are not as clear when they're squished together. So we're on the right side now, on the top. So this would be the chief complaint. And this chief complaint part is also just as tricky as what Sue was trying to say earlier and ask earlier, in that when you ask patients, do you have blurry vision? Do you have double vision? Do you have any sort of strain? I'm going to tell you, if you ask through all these questions, you're going to get yes on almost everything. And whether it's one eye, whether it's two eyes, whether it's, they're just going to tell you yes, 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 and I see it in both eyes. These forms were pre-made. These forms are not ideal in what I would like to do, but in terms of these outreach, we need these here because we need some sort of guidance to follow. So let's go through each one and what each one is. Let's start with blurry vision, double vision, eye strain. So what exactly is blurry vision? I mean, blurry vision is you just don't see well. Everyone will tell you it's blurry. Double vision, some patients will tell you that they see double in terms of one image being two images. And eye strain is any sort of strain or pressure on the eyes. And our purpose is to make eyeglasses. And so my preference generally is to just check yes on this first part in terms of blurry double eye strain, because of what we're trying to do is to make eyeglasses, and our goal is to give them a pair of eyeglasses. And so this is the one that I would usually check the most as opposed to the other ones. We can actually check the other parts in terms of double vision, strains, pain. We can, of course, if a patient mentions it, you should check it. And what you see here with blurry vision, you would see the OD, the OS, the OU, and then you would see the far and the near. So let's go through a little bit of what that means. Blurry vision, if they do, you would check the blurry vision box. And then you would see the OD. OD means right eye. It's a Latin term. I'm not going to try to pronounce it. Everyone can see it here on the screen. OS is the left eye, and OU is both eyes. So once again, OD is the right eye, OS is the left eye, OU is both eyes. So what exactly is blurry vision? Blurry vision is swings are blurry, they're not clear. Blurry vision can be in one eye or even in both eyes. So an eye can be blurry, meaning an eye can need glasses and only just one eye. Most patients who are blurry in one eye, from experience, most will not get glasses or wear eyeglasses just because if they can see well in one eye and not the other eye, we don't walk around covering each eye. We always use both eyes at the same time, and so most patients with blurry in one eye generally don't complain. There may be possibilities of when they look off to the side, then they start noticing that one eye is worse than the other. And that's when these patients, usually when they're older, would come in to check their eyes. And most of the time it's for work or maybe they're driving and they start to notice that the vision is not as clear at night. Blurry vision can be for distance. Blurry vision can be for near. We'll go through that in a little bit. Blurry vision for distance means that, when you're looking at a television, we're talking about the big screen televisions. I know a lot of patients consider their cell phone as their televisions nowadays, and that can be a little bit confusing too. I have quite a few patients who tell me they need glasses for television. Then we make the distance glasses, and it turns out they're looking at the television on their cell phone. So it's important to stress and to try to figure out what they consider their television. So blurry vision can be for far, whether it's driving or whether we're looking at the big screen television. And the conditions that can make that blurry are usually myopia, nearsightedness, hyperopia, farsightedness, or astigmatism. And then blurry and near is generally older individuals, most patients that are 40 and over, give or take. Some patients do have reading problems a little bit earlier in life, and that would be called presbyopia. And these would be reading glasses. Now, there are some patients who have high hyperopia or astigmatism, and they would be blurry at far and near. So blurry vision is a very catch-all term, and blurry vision is more simply fixed with eyeglasses unless there's any sort of retinopathy or any sort of eye disease in the back of the eyes. Double vision. And double vision is, of course, when the patient sees two images. Now, these two images can be side by side or up and down. Generally, double image is because of using two eyes, where one eye is seen and positioned differently than the other eye. This generally is associated with an eye muscle issue. So if a patient sees double vision with two eyes, then usually we would ask them to cover up one eye, and does that double vision disappear? And if the double vision disappears, then this is a two-eye related double vision. This type of double vision, if it's an eye muscle issue, can be corrected with prism. Prism shifts the image of how a person sees. Right now, my father, he had cataract surgery, but even pre-cataract surgery, he sees double vision. I added some prism into his bifocal glasses, but he's still seeing double vision. Prism can move the image up and down, left and right. It gets very, very complicated. Because most two-eye related double vision is an eye muscle issue, eye muscles are never set in stone. So it's not like I can just add simple prism and everything would be cured. It's actually a trial and error method where you would add a little bit prism, see where the muscle settles. If it's still double, then add a little bit or take away some prism. Double image can also be in one eye only. If it's in one eye only, it's something a little more serious. Double vision can, in essence, if it's in one eye only, be that there is something going on inside the eye. The more possible reason would be possibly that the patient had cataract surgery and that the lens inside the eye shifted, or if there's some sort of trauma to the eyes, the patient got hit by a ball, punched in the eyeball, the lens in the eye shifted, or there's some sort of issues on the retina where it folded, which is a little bit more rare. Let's come down to strain on the eyes. Eye strain is also very common. Eye strain is fairly prevalent now in everyone, especially after COVID. Eye strain is when we stare at things too long. The muscles in your eye actually are working to help you focus on things. And so that if you use your eye muscles too long, those eye muscles will break down. Pre-COVID and the beginning of computer use back in the days, eye strain used to be associated with most blue-collar workers, for those who work on computer screens and maybe do things up close a lot. Post-COVID now, even children have eye strain because everything is done on computers or the iPad. Even their homework and their assignments are all done on the iPhone and on the computer systems. Eye strain, if you strain your eyes enough with older individuals, some will get headaches. And so sometimes headaches are caused by eye strain. In children, if you strain your eyes enough and more, then we've noticed that there's a higher prevalence of myopia now, or nearsightedness. So back in the days, it used to be the quote unquote the nerds that wore the eyeglasses, because the nerds were the ones that are always studying or reading a book, so they are straining their eyes more. But nowadays, you really don't have to be a true nerd to strain your eyes, because everyone's staring at some sort of digital device. And because children are still growing, their eyeball is influenced by this eye strain. And what we've noticed as children grows, the strain on the eye causes the eyeball to elongate or to become more nearsighted. And so now there are what's known as myopia treatments nowadays to kind of limit the progression of the myopia in children. And the popular methods are eye drops with atropine, what the Asians call the OKC or the Ortho-K lenses, which they're hard lenses that you wear at night to press on the cornea. And then we have the newer method, which is something called MiSight, which is FDA approved, that can limit the prescription increase in a child. And in the near future, we will have special eyeglasses that has a special side prescription that would actually help limit the progression of a child's vision. But in America, we don't have these special eyeglasses yet. It's available in Hong Kong, it's available in Canada. I get a lot of patients asking why, US is more advanced. We don't have it here. Because US is more advanced, the FDA requires a 3-year study. This is essentially the 3rd year. The FDA requires proof that such a eyeglass lens actually does do what it's supposed to do. And so we should be getting it real soon. Let's go on to the next slide. Pain and redness. So pain and redness sometimes can go hand in hand, and sometimes they can be by itself. If we look at something long enough, we can have basically pain or just the strain around the eyes, and you strain enough, it would be some sort of pain. But generally, these don't have any redness. Now, if something hits the eyes, whether it's a ball, whether it's a fist. Hopefully it's not a fist. You're going to get pain and redness just because the eye is swelling. And then sometimes when we stare at a screen long enough, if you don't strain your eyes, some patients do get dryness, and dryness would come with redness. What's interesting with dryness is that, and that's something a little further down, is that dryness, some patients present with dryness, they have redness in their eyes, and some patients who have dry eyes have no redness, but they'll tell you that their eyes feel sandy or gritty, or they feel like there's needles inside the eye. And so pain and redness doesn't always have to go hand in hand. Pain and redness is generally something a little bit more severe. It may not always be something that we can easily fix with eyeglasses. Some of these patients may have to be referred out to a clinical office. And this next part here, this next one, flashes of light and floaters. Generally, flashes of light and floaters are a red flag. Any patient that really wants to go to the front of the line, as long as they say flashes of light and floaters, these are more of a ocular emergency. Not always. So what flashes of light is that what you would ask a patient is, do you see any flashes of light? Most patients would tell you yes, but these flashes of light generally are off to the side. So do you see any flashes of light off to the side? Whether it's to the left side, whether it's to the right side, or whether you move your eyeball around. Not just that if you're just looking straight and you all of a sudden see a flash of light. And the reason for this is because our eyeball in the back, the retina, sometimes can get detached. And if the retina becomes detached, the retina is floating around back there, and whenever a patient moves their eyes, they will see a flash of light. And generally these movements are left and right movements, and so most of the time the flash of light is off to the left or to the right. Flashes of light and floaters requires a dilation. If you have a detached retina, not only will patients see flashes of light, they will actually get an increase in floaters. We all have floaters. Floaters are what's left in our eye when our eyes are being developed. Think of our eye as flat when we are in our mommy's tummy, and then eventually that flat eye forms a circle and becomes a ball. And when it becomes a ball, whatever's left over that doesn't get absorbed back into the eyeball becomes a floater. And so everyone has floaters, actually. Whether or not these floaters are natural occurrence or whether or not these floaters is because there's a torn retina, then that becomes a big difference. So if you look at a really, really bright light, and then you look at a whitish background, most of us will see something floating across our vision. Some people say they look like little flies that you're trying to catch. Sometimes they look like little circles, which are generally actually blood cells or white blood cells floating across in your vision. They may be squiggly lines. You know, a few floaters here and there, those are generally natural occurrences. These are things that just never got fully absorbed back into our body. Generally, floaters is the question to ask is, you know, if you're sleeping and then one day you wake up and you see a whole bunch of floaters in one eye, then something happened in that eye, and most likely some sort of detachment or some sort of issue going on in that eye, some sort of bleeding. So floaters, the more direct question to ask would be, have you noticed a sudden amount of a bunch of floaters versus do you see floaters? Because we all do have floaters. Flashes of light, some patients will tell you that they see flashes of light, but flashes of light, the more direct question is, do you see flashes of light, whether it's off to the side or up and down, but it's more rare that it's up and down because if a retina were to detach, and if it does, it's usually from the top down, a patient would only see half their vision. They wouldn't even tell you flashes of light, they'll just tell you, I can see the bottom half, I can see the floor, but I can't see anything above that. Anybody have any questions on the flashes of light and floaters part? I would prefer that most of this is not circled, and I believe most eye doctors would be, unless it's something that's very, very patient stresses that they do see flashes of light and floaters.
Dr. Chuang, this is Sue again.
Yes.
You mentioned the eye strain. Is the eye strain same as the migraine?
Right. So eye strain means that when you look at something too long, and when you look at something too long, the eye muscles start straining. And when the eye muscles start straining, this can lead to what's the eye muscles around the eyes would cause what's known as a brow ache. And a brow ache is the space between your eyelashes. I'm sorry, your eyebrows. Eventually, eye strain can build up to a temple ache, which is the area on the outside of your eyebrows. And if you strain enough, some patients would get headaches or what they would consider migraines because they're getting it more often. So yes, eye strain can lead to headaches or even exacerbate migraines.
Thank you.
Okay, so let's go on to the next part. Dry and itchy. Well, are your eyes dry? Yes, they are. Most patients will tell you they are nowadays. We're all staring at a computer screen. We all can't let go of our cell phones. My older daughter, especially, if she's on this meeting, I hope she hears it. My older daughter is, not only is she straining her eyes, she's squinting more. And part of that squinting is because her eyes are super dry. So I'm actually putting ointments in her eyes at night. Sometimes I don't remember, but of course it's not my eyes, it's her eyes. I told her it's up to her to kind of remind me or to do it herself. And so, are your eyes dry? Back in the older days, it's my 60-year-old, 70-year-old, 80-year-olds that have dry eye. Nowadays, post-COVID, my 7 or 8-year-olds also have dry eye. If you stare at something long enough, we blink less when we stare at a computer screen, and as such, our eyes will be more dry. We blink less when we're looking at a digital device, and so dryness is common in almost everyone nowadays. If your eyes are dry enough, it will become itchy. Just like in the wintertime, my hands, I have to wash my hands a lot between patients. I don't really like to use gloves. And as such, when you wash your hands a lot, it becomes dry. When your hands are dry, you will get itchy. So sometimes itchiness is not an allergy issue. Itchiness is a dryness related or dryness caused issue. Dry eye is more straightforward. Dry eye is more easily diagnosed. Dry eye, unfortunately, is not easily fixed. Generally, we use artificial tears, lubrications, warm compresses. But in terms of dryness, the best method is to get enough rest. Or basically just, I joke, don't use your eyes so much, which is nearly impossible nowadays. Then let's keep going. This second part here, we will continue to the pre-testing part. These classes are always best given in person. Unfortunately, we don't have that luxury, so I'm going to try my best to try to explain this online to everybody. And so the next part here on the form, which is on the right side now, we're on to the examination part. And the examination parts, we will first start off with the visual acuity. Visual acuity is how well a person sees. And how well a person sees, generally with visual acuity, we would have some sort of chart or some sort of computer screen. And in terms of the visual acuity parts, if we kind of enlarge that, and with the visual acuity, as everyone can see here, sometimes a patient would enter or come wearing eyeglasses, and sometimes they won't. And so whenever we check visual acuity, we always have to check off the box whether or not they're wearing eyeglasses or without no eyeglasses. And their visual acuity we check is actually for far. Clinically, we sometimes also check the visual acuity for near. But in terms of what we're doing for Tzu here, we will just check for far. And so when a patient comes in or when somebody comes in, you would see whether or not they're wearing eyeglasses or they're not wearing eyeglasses. And then we would start with the OD, and the OD goes across. Whenever we do anything in clinic or whether we do these vision outreach, we always try to check the right eye first and then the left eye. If we always make a habit of always doing right eye first and then the left eye, there generally would be a lot less confusion on which eye did I do first, or which eye was this, or which eye did I just check. So if we all get into the habit of right eye first and then left eye, then usually there shouldn't be any issues. We're only going to do the far parts. The pinhole area we're not going to do. So we're only going to concern ourselves with where it says far, OD, OS. So what we're going to do is we're going to ask patients to read these charts. And sometimes you will just have a paper chart, which we will just tape to the wall. And sometimes we have these projectors. And these projectors are similar to a paper chart. It's just that it projects light onto a screen. And this is more of an older form. Most offices, most of us don't use these projectors anymore. Most of these projectors are usually high up on the wall. When I first started out, my left arm is actually very sore because of these projectors, because one arm would be high up in the air, moving the knobs and the lenses, and then the other hand would be on the machine checking the eyeglasses. Nowadays, we have computer screens. These are digital Snellen charts, and these are a lot more efficient in how we do things, less stress on the eye doctor's body, and also in terms of what we need to change. And if you see, there's a remote control that the eye doctor hangs onto, and we can easily change the letters. We can even isolate a line. We can even just show one letter at a time. And we can easily change between letter charts, number charts for patients who don't know ABCs, and even picture charts for children. And then all the older systems like this, we actually have to change the slide out. And even with this, we actually have to have different paper charts, which we normally do. And so with visual acuity, if a patient wears glasses, then we're going to test the visual acuity with the glasses. And when we test them with the glasses, in terms of where they stand, generally when we go out on these outreach, the distance that a patient stands from the chart and the chart that we use is a 10-foot chart. And so a patient would be standing 10 feet away from where the chart is taped to the wall or any sort of board that we have on hand. Normal distance is actually 20 feet, which is why we normally see, what we know as 20/20. 20/20 means a certain size letter at 20 feet, and this is what an average person should see without glasses, which is what we refer to as 20/20. But because 20 feet is too long, normally we use a 10-foot chart. And most doctor offices would be around 10 feet long-ish. Give or take. The sizing can be resized if we use a digital system versus if we use a charting system. So how do we, see what they got right or wrong? If we use a paper charts, and this is normally what we're normally going to see on these outreach, is that you will see, and it's a little bit blurry on this picture here, on that left side, because this is a 20-foot chart, it'll say 20 over a certain number. And on this chart here, 20/20 is actually on that red bar. So the letters above that red bar is actually 20/20. And so if a patient comes in wearing their eyeglasses, and we're going to cover one eye at a time. So we're going to start with the right eye, and we're going to have the patient cover the left eye. And with their right eye, we're going to ask them what's the lowest line they can read, and then have them start reading the letters to us. Now, how we grade this is that if a patient sees more than half correct, then that line is correct. So let's start with the green bar here, which is number 6. If a patient reads EDF, and that's it, then they did not get that line correct. So let's say if a patient reads EDFC, and that's it, then the patient got that line correct. And that line would be the 20/30 line, which is what's written on the left side. 20/30. I know it's very small. Once you are doing the outreach, you will be able to see it a little bit better. So because this is a 20-foot chart, this will say 20/30. On a 10-foot chart, on that left side, you're going to see 10/15. And so what we're going to write on this, if a patient says EDFC, then they got that line correct, and they cannot get the other ones. Then we go to the next line, because they got that line correct. We go to the next line, which is line number 7, and they say F, and that's it. That means they did not get number 7 correct. The last line they got correct, or more than half correct, is line 6. So that right eye, we are going to write 20/30. And as such, here, on this here, on the visual acuity, we're going to write 20 where it says OD, and then slash, and then you're going to write 30 right behind that. So I'm not able to write directly on that, so everybody can see this. We're going to write 20, and then it will be slash, and then 30. The way this form is done, you write it across, but the way we normally write it is we actually write it on top of each other. Either way, the idea is that you're going to write 20 on the left side of the slash, and then 30 afterwards. And then now we're going to go to the left eye. On the left eye, you're going to have the patient cover the right eye. And when we have the patient cover the right eye, when we ever have patient cover eyes, we use an occluder, or there's an instrument, there's a paddle. Now, best not to use their hands, because if you use their hands, it could kind of look through or peek through. And let's go back to the chart here. And so now we're testing the left eye. And on the left eye, let's start with line number 6 again, and the patient reads E, D, F, C, Z, P. So they read everything. That's great. Let's keep going. And they read F, E, L, O. And they cannot read anything else. That means that that line is correct because they got more than half correct, which means we still continue. And if we still continue, now they only say D and nothing else. Then the last line they got more than half correct is number 7. And number 7, we're not going to write 7, we're going to write what's on the left side. And on the left side, this says 2025. So if that says 2025, so what we had was OD was 2030. And then now we have OS, which is 2025. And then of course we have the here with or without glasses. And if a patient with glasses, we check with glasses. Majority of the patients will come in without glasses. Majority of the patients come to these outreach because they need glasses. And so if during these outreach, we're going to use a 10-foot chart, you will notice that we're going to write 10 over a certain number versus 20 over a certain number. So then let's go on to the next part. Next part of the examination here is current eyeglasses. If a patient wears eyeglasses, then we will try to check and see what their prescription is. If none, you can check none, or usually anything on any sort of legal document. If you don't write anything, it's considered none. And that's actually a very tricky thing too, because if the doctor does something and the doctor doesn't write it down, if there are anything that's brought up in a court of law, it is considered the doctor didn't do it because the doctor didn't write it. But let's come back to basically if we don't write anything down, it means that it's none. So here we have none, which you can check none, or we can just kind of leave it alone, leave it blank. I would just leave it blank because usually what happens is, what I've noticed when we go out on these outreach is sometimes a patient may not bring it up that they have a pair of glasses on them until they reach the doctor, and they will pull it out of their pocket and say, oh yeah, I use this. And yet when they're going through the pre-testing, they don't say anything to any of the volunteers. So current eyeglasses. Current eyeglasses, we're going to check what their prescription is. We're going to try to learn a little bit of notation of eyeglasses next. So we have the sphere, we have the cylinder, we have the axis, and we have the ADD. The ADD means what they need for reading in addition to their distance. So the sphere, the cylinder, the axis is what's needed for distance usually. And of course, we go all the way across on the OD, and we go all the way across on the OS. And how do we check these eyeglasses? We have machines. These are the newer machines. These are the automated machines. Right now for the New York team, we have two different what's known as lensometers. These are automated machines that can check the prescription of the eyeglasses. There are older versions. In terms of eye docs in general, we all prefer manual versions versus these automatic ones. But something is better than nothing, so this is what we have now to use. I am not sure or 100% of which machine the New Jersey team will end up getting, but these machines are all very similar. These are the two units that we use right now for the New York team. On the left is the Reichert version. On the right is the Nidec version. The one on the left is actually the one that will be seen more often, and the one that is in terms of design is what's most prevalent, but unfortunately I don't have any additional pictures that I can take. The one on the right actually has more pictures, so I'm going to have more pictures on the right versus the one on the left. But in terms of use, they're very similar. If you see that instrument, the Reichert machine on the left, you will see here there's a right eye, there's a left eye, and all instruments has a right eye and a left eye. And then you will see numbers below that. And the numbers below that, you will see the S, the C, and the A. So the S is the sphere, the C is the cylinder, and the A is the axis. These machines, so this picture here, this is what I have available. We're going to put the eyeglasses in this machine, and in this machine, there's a little lever in the middle there. And there's a lever on the side. So if you see the side view, there's a lever on the side. And don't get too worried, don't get too concerned. Once everyone has the opportunity to kind of feel and touch the machines in person, you will grasp this a lot quicker. Just for now, it's just to give everybody a basic general idea. We have our pair of glasses. In our pair of glasses, what you're going to do is the bottom of the glasses goes in towards the base of that machine. And the position always has to be this way when we measure it. So the bottom of the eyeglasses goes inward. And it goes inward, the platform has to go flat up against the glasses. And then on the screen, you will see once again the S, the C, and the A's. The picture on that left is actually for spherical. The picture on the right is actually for progressive glasses. There are different types of glasses that are available. There are single vision, which is what we make at Tzu-Chi. Our lenses are only for distance only or for reading only. And then we do have older patients that come in and they need for far and they need for reading. We don't make two pairs of glasses for a patient. We will only make one pair of glasses for a patient. So ask the patient which one is more important to you, whether it's for driving, whether it's for reading. We will only make one pair of eyeglasses. In the optical offices or in eyeglasses stores, sometimes we can make eyeglasses that are together. What's known as bifocals, which has a line, and what's known as progressives, which have no line. And with bifocals, the glasses would look something like this. And it has a little piece on the bottom. That's a bifocal. Some patients wear what's known as a progressive. So this here is a bifocal. Some patients will wear what's known as a progressive, and a progressive is actually a bifocal, but you don't see any lines in there. And a progressive is trickier because a progressive, you don't see the lines. There's an imaginary line in these progressives. And so the progressives, only the center is clear. And the side is actually all blurry in a progressive. So when a patient walks into these outreach, if they're wearing a bifocal, we can actually see that very simply. But if they're wearing a progressive, it gets very tricky. And so sometimes we will check the glasses if it's a single vision, but sometimes it's a progressive, and when you check it, when you put it into that machine, it'll give you really, really weird and strange numbers all over. And it's because the progressive actually has different zones and has different powers. And so if anyone sees anything like that happening, it's best just not to check those glasses and just let the doctor check it. In terms of also even bifocals, right now the New York team, some volunteers do know how to check bifocals, some actually don't. In terms of bifocals, in terms of progressives, if anyone sees these type of glasses, it's best to just to let the doctor check the prescription. But this picture here, if you look on the right, if you see that weird line come out, it's because this is actually the mode for checking progressive lenses. And so if you see the one on the right, you see the sphere is plus 50, the cylinder is minus a quarter, and the axis is 79. And so let's go through a little bit of how to write and what the notations are in terms of nearsightedness, farsightedness, and then if we need reading glasses or astigmatism also. So let's start with a simple nearsightedness prescription. Nearsightedness, we always use a minus sign. And somebody that is nearsighted for OD, the right eye, is minus 1.00. So this is the correct way of writing something, minus 1.00. But when we talk about a prescription, most people will say, I am minus 100. So what they're trying to say is when I am minus 100, it means that I am minus 1.00. And when we write these notations, if let's say it's for OD and I am minus 1.00, some doctors you will see they will write minus 1.00 SPH. And what this means is that this person is just minus 1.00 nearsighted. They don't have any astigmatism. They're just nearsighted. Or sometimes you will just see what's written here, which is minus 1.00. I am still a little bit more old-fashioned. I still will write minus 1.00 SPH just so that it doesn't cause any confusion at all whether or not they have astigmatism. And I would write OS minus 1.50 if that's the prescription SPH. So this patient is just nearsighted on the right eye, nearsighted on the left eye. Farsightedness means that a person can see far better than near, but this term is a little bit trickier. When the farsightedness is low, these patients have great vision. So why would these patients come see you? Generally, these farsightedness patients are actually older. And farsightedness has to do with the eye muscles. And that's also where we come back to the eye strain. A patient that's farsightedness can be straining their eyes to help them focus. And farsightedness, we use a plus sign. So the example of the farsightedness patient on the right eye is plus 1.00 or plus 1.50. Now there are some places that would just write 1.00. So farsightedness, OD, some places would just write 1.00. And once again, I am a stickler for the old-fashioned way and not to cause any confusions. So if you don't write plus, it's considered a plus actually. But what I would like most and all volunteers to do, if possible, is to just write that plus. Because what happens is sometimes on papers, there might be a little mark there. And when we look at this little, and then there's a little mark there, and you would be like, oh, this is a minus 1.00. Right? It can get confused very easily. So if you put a plus or minus in front of it, there would never be any confusions. And a minus must always be put in front of a nearsightedness prescription. So if we get into the habit of writing the plus and the minus, we can get rid of all confusions there. So some patients are just nearsighted, which is the first example. Some patients are just farsighted, which is the second example. And here we see nearsightedness is when light goes into your eye and the image is in front of your retina. And so we use concave lenses, or lenses that curve inward, to try to change the position of where that image falls so that it becomes on the back of the eye, which is on the retina. The middle part is farsightedness, where if the image comes in, it's behind the retina. And so we use convex lenses. And these are more straightforward because there's only one image when it's nearsighted or farsighted. So one image is off. But when you have astigmatism, and this picture doesn't show it as much, astigmatism is actually when you have two images that are in the wrong position. And astigmatism is something we call cylinder. So the sphere was the S, the C now is the cylinder, and astigmatism is that when light goes into your eye, instead of having one image that's off, you actually have two major images that are off. And astigmatism has to do more with how the front of the eye is curved, and the front of the eye is curved more like a football. And when I was little, I used to wonder, what are they talking about? My eye is like a football, not like a soccer or a basketball. That doesn't make sense. So we're talking about the curvature of the front of the eye, the cornea, where on top, the cornea is more round. Then farsightedness, nearsightedness has to do with the length of the eyeball. But astigmatism, which is the picture on the bottom, has to do with the curvature of the front of the eye, the cornea, where one end is longer and one end is shorter. And so we have some patients who can have just astigmatism. So a patient could be just astigmatic and they are not farsighted and they are not nearsighted. And so these are the notations for astigmatism. So the first notation is the S, which is the sphere. So if we look at the top example, this is a patient that just has astigmatism. If you see here plano, plano means 0. Instead of writing 0.00, we generally write plano. So plano means that a patient is not nearsighted, a patient is not farsighted, and the second number is the cylinder, which is minus 1.50. Now, when a patient has cylinder, once again, cylinder means that your eyeball is more oval instead of being round. Now, when an eyeball is more oval, we can be oval horizontally, we can be oval vertically, or we can be oval at an angle, which is oblique, or it could be at this angle. And so we always have to know where that astigmatism is when we make the eyeglasses, because if your eyeball is oval, we have to line up the lenses with that ovalness. So if this first example, if your eyeball is oval horizontally, the lenses we make have to line up at the 180 line horizontally. Now, if a patient's astigmatism is horizontal, which is 180, horizontal is at the 180 axis, and we make the astigmatism at a 90 axis, then the patient's not going to see well. And so that's why it's very important to know the prescription to line up everything correctly. Otherwise, we can do the best exam in the world, but when they pick up their glasses, they're going to say, I don't see. Now, there are some patients who are nearsighted with astigmatism, and nearsighted, so we added the nearsightedness. So once again, the first part is the sphere, and the sphere, we can add in the nearsighted, or we can add in the farsighted. So if you see OD, a person that's nearsighted is minus 1.00 nearsighted. Now, because they have astigmatism, the C, the cylinder, is minus 1.50, and the position of that astigmatism is horizontally or at 180. Now, if a person is farsighted, then we go down to the bottom here. On the right eye, it's plus 1.00. Their astigmatism is minus 150, and the axis is horizontal again at 180. So these are notations of a person that's nearsighted with astigmatism or a patient that's farsighted with astigmatism. I'm going to slow down a little bit now. Does anybody have any questions on notations and how to write nearsighted, farsightedness, and astigmatism?
Yes, hello, doctor. This is Chris.
Hello, Chris.
Yes, question just going back a little bit. As far as identifying progressive glasses, do all progressive glasses or bifocals have an etching in the lens where if we hold it up to the light, you can see a small etching?
Yes, Chris. So progressives do. Bifocals don't. So progressives has etchings on the left and the right side of that lens itself. It's very tough to see. You have to hold it up to a really bright light or some sort of object that's a little bit more wavy to try to catch that. Unfortunately, this is something better taught in person. If you don't hold up the progressive to the light, you can actually hold it against a straight line. And when you hold the progressive lens up to a straight line, like if we use the edge of a table and you lift up that frame about 4 inches off it, if you move that frame left and right and you look at that straight line through the lens, you will notice that the bottom half of that straight line would start shifting left and right in a progressive lens. And that's generally how we tell if that is a progressive glass.
All right. And for the novice, like most of us volunteers, would you recommend we attempt that, or is that a little too complicated for us to identify?
Because most volunteers shift and change, and because this is not everybody's profession, what we've been doing for the New York team is that if we suspect that it is a progressive, we will just hand it over to the doctor to check versus checking it ourselves.
All right. One other point, the legal importance, writing 1.0, 1.5, it can be a little confusing sometimes, and we're bound to make mistakes. Could you touch on the legal importance of how to cross it out and to rewrite it? So if we wrote 1.8 instead of 1.5, how we actually go about correcting our mistake.
Yes, Chris. So Chris made a very important point, and this is something that we commonly see. Nobody is perfect, neither is the doctor, and it happens with me too. So let's say if we were to write something and we write it incorrectly. So let's say if it's a prescription and we have our OD and we write, minus 1.00, and we notice that it's not correct. And it's actually minus 1.25. And what we normally see with some volunteers is that some would just kind of go in and do this and then try to make that a little bit more. That's not the correct way. If you notice that when you write something and you notice that that's not correct, what we will do is do one line across it, put your initial, and then next to it, we will write it again. And so why do we do this? Why do we do that? One is basically you are owning up to your mistake. And so this from a legal standpoint shows that, okay, it was 1.25 and you wrote it wrong and you wrote 1.00. And so this is something that's from a legal standpoint is what we need to do, versus if we wrote it wrong and we try to either write it over it, or what we also notice is some volunteers have been doing this. And all these are not correct, and all these will get us in trouble, because what the lawyer is going to do is they're going to have a field day and they're going to say, well, what are you trying to hide back there when you do this, when you try to cover everything up? And so this middle part here is the correct way. You're going to put one line through your mistake, put your initial there, and then you're going to write what is supposed to be correct right underneath it or right next to it. Chris, does that answer what you were asking?
Yes, thank you.
I believe we're running a bit low on time. If nobody's in a rush, just bear with me. Let me just go through a little bit more, as much as we can. Okay, so nearsightedness, farsightedness, and astigmatism. So there are some that are just nearsighted, some that are just farsighted, some that have nearsightedness with astigmatism, some has farsighted with astigmatism. Now to throw another whole monkey wrench into the whole thing, now we have what's known as ADD. ADD means, and these are usually for older individuals, ADD is what we need in addition to our distance. We need this extra prescription in addition to our distance for us to read. And ADD is usually for reading glasses. And this is very important when we make reading glasses. And there are also some patients who don't need reading glasses because they are nearsighted. So if we take a look at that first example, this patient, right eye is minus 1.00, left eye is minus 1.50, but they're young enough that their ADD is only plus 1.00, which means that when we make reading glasses for this patient, the right eye is actually 0 in terms of their reading prescription, because the right eye is minus 1.00, and for the reading, they need additional plus 1.00. Well, minus 1.00 added to plus 1.00 becomes 0. So for this patient, the reading prescription is actually 0 on the right eye. On the left eye, this patient's prescription is actually minus 0.50, which is very minimal, which means for this patient, and this patient is actually very close to my own prescription, this patient will need driving glasses for far. But when this patient wants to read, he or she will just take off their glasses. And so that's why a lot of nearsightedness patients don't make bifocals or progressives, because they have the option of just taking off their glasses. A patient that's farsighted, this is where it gets tougher. A patient that's farsighted, if their number is plus 1.00 on the right eye and plus 1.50 on the left eye, this patient, when they were young, actually did not need glasses, nor did they want glasses. They actually have the prescription when they were young too. But because their eye muscles can help them hold out, this patient, when they were young, didn't wear anything, but now that they're older, those eye muscles are weaker. They need this prescription for distance, and their ADD, in terms of their reading, they need even more. So if we look at the right eye, this farsighted patient is plus 1.00 on the right eye. And in addition, for reading, they need another plus 1.00. So when we make the reading glasses, the right eye is actually plus 200. And the left eye is actually plus 250, which means this patient needs reading glasses, or else they're not going to see anything up close. So ADD means in addition to your distance. And when we make these glasses, when we put these ADD in, we do it in addition to the sphere part, the S part, not the cylinder part, but the S part. And so if we have, let's say, the right eye and a patient has astigmatism, plus 1.00 minus 1.25, axis 180. And if their ADD is plus 1.00, then when we make the glasses, the prescription would be plus 2.00 minus 1.25, axis 180. And so this is actually what their reading prescription is when you add in the ADD. The ADD goes onto the sphere part. So we have the sphere, the S, the C, the cylinder, and the A, the axis. The ADD goes only onto the sphere part. And then you just copy everything down. The cylinder down, the axis down, it will all stay the same. Next part here is the color test. Color test, we use what's known as an Ishihara book. Color test, this is the right eye, the left eye. We use this book here. This book is a 14-page book. There are 14 different plates in there. Now, in this book, we test one eye, right eye, we test left eye, but sometimes in the interest of time, we would just test both eyes. And depending on the doctor, most doctors for these screenings actually would prefer just both eyes. But I tell most volunteers, if we have time and there are not a lot of patients, then let's just do this one eye at a time, right eye, left eye. And then we leave OU, which is both eyes, blank. But if we are very busy that day, then we're just going to do both eyes together. We're not going to do right eye and left eye separately. And it's basically based on 14 different plates or 14 different pages. First page is a test page. First page everybody will see. And it looks something like this. And you just flip through each page. And how we're going to note this is that if a patient gets everything correct, then it's 14 over 14. It's whatever the patient's got correct over the amount of plates. First page everybody sees. One page should be blank for a patient with no deficiencies. So one page, most patients would pause. Just ask them, do you see a number or not? One page has one squiggly line and one page has two squiggly lines. We have the patients trace the lines from X to X. You can have the patients either use a Q-tip and trace it on the book, or you can have the patients trace it on the table in front of them. As long as the patient goes in the correct squiggly path, it should be correct. Try not to have anybody try not to have the patients touch these books, these plates. These plates, if our fingers have certain oils, and the oils, if we touch it enough, these plates won't be as accurate as it can be. Technically, when we do these, we actually need to wear gloves ourselves as volunteers, but just hold the edges of the book, should be fine. And the distance that we test this is generally the tester is opposite the patient. So we would have a table, usually these are fold out tables. You have patient on one side, you're on the other side. Just kind of put the book midway between the table and at a slight angle, and it should be enough. Generally, it's about 50 centimeters or 19 to 20 inches. So arm's length is pretty much enough with just good room lighting. Each book has an answer sheet in there. It tells you what a normal person would see in terms of numbers. Please make sure, and this happened to us once, we went out on one of these outreach. We had really not as much volunteers that day. One volunteer was actually testing everybody, and then we noticed that something was wrong. And it turns out that this volunteer actually had color deficiency. please try to have a volunteer that doesn't have color deficiency do these tests. And so this part is pretty straightforward. Next, we have the stereo. The stereo here, this is what it looks like. It's called seconds of arc. We use the Randall stereo test. With this test, we have a polarized glasses that we're going to have a patient wear. If somebody wears glasses or reading glasses, then you're going to have to put these polarized glasses over those reading glasses or glasses. Stereo test is a little bit more tricky. Stereo test is how a person sees 3D. We will use the section on the left on top, the circles. So we see there's a bunch of circles there. There are 10 rectangular squared circles. And how this works is that, once again, you're going to hold the book. Now, don't move the stereo book and don't have the patient move. And that's always the key to this test. When you move the book or when the patient moves their head around, you will actually see 3D better, because what these polarized glasses does is actually it puts different images into our eyes. And if you notice, if you yourself were to look at something and you cover up each eye, the image shifts. So if we look at an image from the right eye, if we look at an image from the left eye, the image is actually a little bit in different positions. And that different position is what allows our brain to form that 3D image. And that's what these polarized glasses are supposed to do. So if you move your head around or if you move the book around, it's actually a form of cheating. So if a patient is moving, just tell them, oh, just stay still, try not to move, just tell me. And what you're going to have the patient tell you is, if we look at here, number 1, the circle, which circle looks like it's coming out at you? Which circle looks like it's floating? And even without 3D glasses, actually, you can see most of these are a little bit blurrier. So if you look at number 1, you can see which circle, left, middle, or right, looks like it's floating out at you. Right now, none of us are wearing stereo glasses. And I can tell you right now, number 1, the answer is the left one. Okay, so how we score these is that we pick the last one that they get correct. And the last one that they get correct means that they have to have 2 consecutive incorrects. So how this works is, if a patient gets number 1 correct, then we keep going. Number 2 correct, we keep going. Number 3 is wrong. Okay, let's see what they do on number 4. Number 4 is correct. Then we keep going. So number 4 is correct. Number 5 is wrong. Number 6 is wrong. So they have 2 wrongs. Now, then the last one they got correct is number 4. So once a patient got 2 incorrect, it's the last one that they got correct. If a patient gets 1 wrong, we keep going just to try to see if they get the next one correct. So the patient got number 4 correct. We will come back to the answer key, and we're not going to write 4 there. We're going to see what 4 correlates to, and 4 correlates to 100 seconds of arc. So in this area here, we're going to write 100. We're not going to write 4. So we don't write 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We're going to write what it corresponds to in seconds of arc. So 4 corresponds to 100. So we're going to write 100 here. Next would be the IOPs. IOP means intraocular pressure. There are many different ways to take your eye pressure. What we use here at Tzu Chi is a NCT, non-contact tonometer. NCT means nothing touches the eye. The GAT is the Goldman applanation. So the GAT touches the eye. We don't use anything that touches the eye here at Tzu Chi right now currently, nor do I foresee us using anything that would touch the eye. going forward for the fact that anything that touches the eye needs an anesthetic. Or there are actually newer versions that don't require an anesthetic that uses a disposable probe. But one of the teachings of Tzu Chi is that we try to recycle and reuse as much as we can. And as such, the NCT, which is a puff of air, would be the method that we would be using. We would use other methods when we generally treat for glaucoma, and the other methods are the gold standard. But as a screening tool and as a routine exam tool, the NCT is enough. The soft and equal, we would leave that to the doctor. The soft and equal would be for patients that cannot take the eye pressure. NCTs are done on these machines. We would be using a combination machine. These combination machine would take a prescription of what the patient's current condition is, and there would be a probe that comes out that actually blows air. And so this is what the machines look like. This is the side view. You have the joystick that moves this machine up and down. The joystick can be rotated, and the joystick can be moved left and right. We have the chin rest, which is from the front view, which can raise the patient up and down. And the chin rest, there's a line on the side there, which you use the chin rest to line the patient's eye level up to the line on the side. Otherwise, the machine won't be able to go high enough or low enough. It won't have enough range to measure the patient. This is the auto-refractor part. We have to make sure that the machine is set to, if you look on top, RK and T. RK is the auto-refractor, the NT is the tonometry. The 3D and the A means that the machine would automatically do the measurements. When it's close enough, it would align itself automatically. So sometimes the machine might get a little bit wonky, feels a little bit weird, or it's not moving, it's not working. It's because the setting on top there is incorrect. Once we want to do the NCT, if you look, this is actually the setting for an auto-refractor, and the face is nice and flat. If we're going to do the IOPs, which is the intraocular pressure, or the pressure of the eye, the puff of air, there's a little tip that comes out. This tip does not touch a patient's eye, but it does get pretty darn close. And once again, IOPs, the non-contact is what we're going to be using. Now, it's very important that when we take these eye pressures, that they are within 2 of each other. So normal eye pressure is between 12 and 21. Generally, there are some books that says it's between 12 and 22. But just for now, take as normal IOP, normal pressure is between 12 and 21. And generally those readings have to be within 2 of each other. So if we get 18 on one eye and we get 20 on the other eye, great, that's good enough. I know in school they teach us to do the average of 3 readings. And I'm going to tell you right now, it's very tough to get 6 reading on anybody, especially children. So what I would like most volunteers to do, and what I would like everyone to do, is take that first reading. And that's always the best reading, because the second and third readings, the patient is already apprehensive and uncomfortable. So if your first reading is 12 and your second reading is 13, perfect, great. We're going to write 12 on the right eye, 13 on the left eye, and we're going to leave it at that. But if you get 12 and 15, okay then, something's a little off, there are more than 2. Then 12, of course, is the right eye, as I told everybody earlier, right eye first. Then the 15 we would remeasure. And if the 15 now is 13, then perfect. So now we're going to do 12 and 13. And we're going to stop there. Autorefractor, we write the sphere, the cylinder, the axis, so that's very straightforward. we're not going to do anything that's wet. So we're not going to use that right side of that form. Wet means that we put eye drops. Generally, we do this for children, but even for now, we don't do any eye drops. Pupillary distance. Pupillary distance is important because we have to line up the centering of a patient's eye with the centering of the lenses. And everybody's eye centering is different. So pupillary distance is the distance between your eyes. Pupillary distance when we look straight is larger because your eyes are more straight. But when we look up close, when we look at a computer, when we look at our book or our cell phone, our eye actually moves in a little bit closer towards each other, or it slants in towards each other. So PDs are larger for far and smaller for near. And when we write PD notations, you will see far and near. We will usually do binocular, which is the top part. We will not be doing the bottom part, monocular or monocular. So we will only write PDs on the top, for far, for near. Now, generally, for school children, or when we go out to the school, we only measure far because generally children is for far. But if you can, during the outreach, measure the far and measure the near. And when we measure these things, once again, it's the centering of the eyes, so we could center the lenses. We use these machines, which is a pupillometer. And a pupillometer, if you see, there's the right eye, there's the left eye. Well, if the right eye and the left eye numbers aren't too far apart, we're just going to take that number in the middle. And that number in the middle, if you see right now, is 63. And 63 is on the average end of where most patients' PD is for far. And for far, there's a setting, which is a black knob on top there. And we're going to do that setting for infinity, which is far. And then for near, we generally set it to 40 or 50 centimeters. I've been having everybody set it to about 50 centimeters because that's generally the range of where most computer-ish or where we hold our cell phone versus the 40 that they teach in school. Okay. And so that's the positioning. And you always have to make sure that the pupillometer, you are straight. So the bottom right hand where the ladies are is the correct position. The upper left picture, the gentleman is a little bit more slanted, and that is not the correct method. So when you do a pupillometer, you want that machine to be horizontal. You don't want it to be you're high up versus the patient, and you don't want it to be you are too low versus the patient. You want that machine to be straight, where you are level with the patient. And these are the blanks. Every blank has a centering, and which is why it's very important that we center the lens to the centering of a patient's eye. So this won't cause eye strain. All right, guys. Everyone, this is pretty much the end of it. I know I rushed through the end of this part, but this is always best hands-on. If anybody has any extra questions, always feel free to reach out to me. I will send this slide over to Catherine. Catherine will have a copy. Everyone is welcome to it. Anybody have any extra questions to ask me for today?
Thank you so much, Dr. James, for this wonderful session.